A 5-year-old boy presents with hyponatremia. Following recent neurosurgery. For the resection of a cerebral tumor. The patient exhibits symptoms of moderate hyponatremia, including polyuria and decreased skin turgor. There is also clinical evidence of extracellular fluid depletion with hypotension. Polyuria and dehydration. In the context of recent neurosurgery for a cerebral tumor, raise concerns about electrolyte imbalances, potentially related to hyponatremia. Given the information provided, cerebral salt wasting could be considered in the differential diagnosis. In CSW, despite hyponatremia, urine osmolality tends to be elevated, and sodium concentration is usually above 40 m. EQ/L. Check for signs of extracellular fluid depletion, consistent with CSW. Distinguish this from CID, where extracellular volume is usually normal or slightly increased. Administer isotonic saline and observe the response. In CSW, volume repletion should lead to dilute urine and correction of hyponatremia due to the removal of the hypovolemic stimulus to antidiuretic hormone release.
The debate over whether cerebral salt wasting truly exists creates confusion in diagnosis and treatment approaches.
Distinguishing between cerebral salt wasting and syndrome of inappropriate secretion of antidiuretic hormone based solely on laboratory findings can be challenging, as both may share similar characteristics.
The criteria for diagnosing cerebral salt wasting lack universal agreement, leading to potential misdiagnoses or delayed recognition.
The unclear understanding of the mechanisms causing renal salt wasting in cerebral disease complicates accurate diagnosis and targeted treatment.
Determining appropriate fluid interventions, especially in patients with subarachnoid hemorrhage, is complicated by conflicting perspectives on volume expansion and sodium excretion.
The disputed existence of cerebral salt wasting contributes to uncertainty regarding its incidence, making it difficult to establish its prevalence among patients with CNS disease.
The overlap in clinical and laboratory features between CSW and SIAD raises questions about the necessity of distinguishing between the two in certain clinical scenarios.
challenges in accurately measuring fractional excretion of uric acid, and demonstrating evidence of net negative sodium balance. Limit the reliability of these tests in diagnosing CSW.
Choosing between hypertonic saline and isotonic saline as initial therapies for CSW remains debatable, with potential risks associated with fluid restriction or inappropriate volume repletion.
The transient nature of CSW suggests that long-term therapy may not be necessary, but the lack of extensive data on its resolution complicates the management approach.